Good morning, everyone. We are going to start. I'm impressed to hell that you're all here at this hour. I think you either suffer from insomnia, you are wakened by hunger pains, or you really do just love NTM disease. How many of you are from the West Coast? Raise of hands. Just a couple. Very impressive. You are the star performers. Okay, I'm going to look for my mouse here. Where's the... Oh, here it is. Okay, this is the Experts versus AI Challenge, and here we go. I'm PJ McShane from the University of Texas in Tyler. I am accompanied by my friends and esteemed colleagues, Dr. Colin Swenson and Dr. Wendy Drummond. Thank you to Peer Review for providing this session this morning, and INSMED for providing the educational grant for this symposium. And if you haven't already, please complete the pre-event survey. Look out for additional polling during the presentation and submit your questions, and we'll answer them during the Q&A period. We have this, for the in-person audience, we can scan this to your personal device to ask your questions, and you could win an Amazon card. Okay, so a little bit more housekeeping information. Visit us at peerreview.com/24NTM lung disease. View the slides and practice aids now and download them after the event. So our goals for today, we will hopefully enhance your ability to identify risk factors, comorbid conditions, and signs and symptoms of NTM lung disease to facilitate early diagnosis. We'll hope to equip you with strategies to work with the care team to create a personalized treatment plans for your patients with NTM lung disease and provide guidance on employing guideline-based strategies to help patients manage adverse events. So, we will start with some questions up front here. Answer this question. Please select your degree, profession. Just know the results will not be shown. These are logged. Big Brother is watching you. And you have some music to answer these questions too. He's going to advance. It seems like a long time. Okay. Please select the category or role that best describes you. Again, the results will not be shown. Oh, okay. In the care of approximately how many patients with NTM lung disease are you involved each month? Results will not be shown. Yeah. Which of the following practice settings is applicable to you? Results will not be shown. So now we'll answer something more substantial. A 75-year-old woman with chronic cough presents for care to a pulmonologist, and she says that in addition to weight loss, she has experienced night sweats for the past several weeks. If NTM is suspected, what would the next best step be? Start empiric antibiotic therapy immediately, obtain a sputum sample for acid-fast bacilli AFB culture, order a high-resolution CT scan of the chest, test for tuberculosis using TB skin test, or interferon gamma release assay, or I'm not sure. Now answer this question. The previously introduced 75-year-old patient has been confirmed to have MAC lung disease. How would you proceed with treatment? Treat with a short course of antibiotics for 2 weeks. Start high-dose corticosteroids to reduce lung inflammation. Initiate a 3-drug regimen with a macrolide, ethambutol, and rifamycin. Monitor the patient without antibiotics unless her symptoms worsen. Or I'm not sure. I have to read more. Answer this question. The patient was confirmed to have macrolide-sensitive and cavitary MAC lung disease. She is now on a daily regimen of azithromycin, rifampin, and ethambutol. She's experiencing adverse events that include rash, gastrointestinal effects such as vomiting, and now she thinks she's noticing some changes in her vision. What do you do now? Should you continue the current regimen and add an antiemetic to manage the gastrointestinal symptoms? Stop all antibiotics for 2 weeks, then reintroduce one at a time. Switch her to a twice-weekly dosing schedule of the current regimen. Discontinue ethambutol and refer her to an ophthalmologic evaluation, or I'm not sure. Just can't get enough questions. The ethambutol was replaced with clofazimine, and the vision changes improved. The rash resolved after a period of stopping the other medicines. The regimen was resumed successfully. However, after 6 months, the patient has had failure of culture conversion. What do you do next? Add amikacin to the current regimen. Switch the patient to corticosteroids to reduce inflammation. Continue the current regimen for another 6 months to allow more time for culture conversion. Switch from azithromycin to clarithromycin for better efficacy, or I'm not sure. Another question. How often do you consider the use of inhaled amikacin in treatment-naive patients with non-cavitary MAC lung disease? Never. Sometimes, frequently, always. I'm not sure. It doesn't apply to me. And you won't know the answers to your questions yet. So now I have the pleasure of introducing my friend and colleague, Dr. Colin Swenson, who is a living example of the fact that men look better as they age.
Lies, lies, lies. And women lie better as they age. Interesting music choices. I kind of feel like I'm in a Quentin Tarantino movie. Hopefully, nothing bad happens. But thank you all for joining us this early. It's a little distracting because there's an echo, but I will try to talk through it. So first off, just a quick sort of overview of NTM. So the most common NTM that we find in our environment are MAC and abscessus. So in general, in clinical practice, the most common pathogen you'll see is MAC in 80% of isolates. After that, you have abscessus, and depending on where you are in the country, you're going to see some other pathogens. In general, we lump these into 2 broad categories, the slow growers and the rapid growers. And that really refers to how much time it takes to isolate these organisms on culture. So the slow growers, for instance, MAC, which includes both avium, intracellulare, and chimera, take longer than 7 days generally to isolate on culture, as opposed to the rapid growers. These are your abscessus, your chelone, and your fortuitum, take, generally speaking, under 7 days. Now, it should be noted there are over 200 species of NTM that have been recognized, and that number is growing. Not all of them are pathogens. And I understand this is a very busy slide, especially for a 6 a.m. talk, but the broad takeaways, this is an incidence and a prevalence slide. But what the takeaways are is that you're many times more likely to develop this infection if you're over the age of 60. Over the age of 60, you're about 7 times as likely to develop this disease as somebody under the age of 60. And then on the x-axis, you can see our timeline. And you can see that these numbers are all going up year after year to the tune of about 8% per year. NTM lung disease diagnosis is oftentimes missed or under-recognized. So I can't tell you how many times in clinic we get referrals for patients who have been diagnosed with COPD, even if they're lifelong non-smokers, or asthma on inhaled corticosteroids, when in fact, while they may have had those as comorbidities, they actually have NTM lung disease. So in general, it can take almost 2 years from the time of symptom onset of NTM lung disease to the actual diagnosis of it. And it can be challenging because of the sort of non-specific nature of some of the symptoms, which can be fatigue, can be weight loss, it can be night sweats, and we'll get to that in the later slides. So what are some of the impacts of a delayed diagnosis and, in fact, the diagnosis of NTM lung disease? So in some series, almost 100% of patients have progressive findings of their disease on CAT scans if they are not treated. So significant radiographic deterioration. It's associated with a 4.3-fold higher incidence of respiratory failure than in the general public. And there's worse outcomes in general, particularly for quality of life scores compared with the general population. These folks have longer hospital stays when they are admitted to the hospital, so 44.61 days as opposed to 8.03 days for patients without NTM. And in one case series over the span of 3 years, if patients were not treated for their NTM lung disease, almost 2/3 of them ended up with progressive MAC lung disease if not treated. And we used to like to say that this infection was something people died with, not died from, and we now know that that's simply not true. So 8-year all-cause mortality is significantly elevated for this patient population. You can see this Kaplan-Meier curves here. And I alluded to this earlier, but some of the general symptoms we find with NTM lung disease include sort of the pulmonary category, which is chronic cough. This can be either dry or it can be productive. Not all of these coughs are copious amounts of sputum. Shortness of breath is extremely common. Hemoptysis, and usually it's low-grade, intermittent, mild hemoptysis, but it can be more severe. Also, these patients can have pleuritic chest pain. I've had some patients in clinic who present solely with pleuritic chest pain. And then, of course, there are the constitutional symptoms, and this includes fatigue, weight loss that I alluded to earlier, fever, night sweats. And one of the most frustrating aspects of this infection is that these patients can sort of relapse and improve. So it's sort of an undulating, waxing and waning pattern. And that can make sometimes the decision to treat with antibiotics difficult. There are 2 main phenotypes that we see with NTM lung disease. The first one, and these are a little bit reversed, but the most common one that we see in clinic is the nodular bronchiectatic phenotype. In older days, we referred to this as the Lady Windermere syndrome. So in this phenotype, the patients tend to be female. They tend to be older than the age of 65, and they have sort of typical body habitus and skeletal abnormalities that are more common, including lower BMI, They tend to be taller. They tend to have thoracic skeletal abnormalities like pes excavatum, scoliosis, mitral valve prolapse can be common, especially those with Marfan characteristics. And radiographically, what we see is more of sort of a nodular interstitial infiltrate on the CAT scan. And what the high-resolution CAT scans will almost always show is sort of tree and bud nodularities, which is rather nonspecific. So there are combined host environmental and organism or pathogen factors that sort of intersect to confer disease susceptibility. So on the environmental side, we know that these organisms tend to be very common in the environment. They are ubiquitous. They're almost impossible to evade completely. There is sort of a geographical predominance to some of these organisms. We know that they're very common in the municipal water supply, water in general, but the municipal water supply, also in soil and soil dusts. There are animal reservoirs, and of course, as I mentioned, it tends to be higher in areas with high transvaporation. So lots of surface water, humidity, and so forth. That's one of the reasons we see it so commonly in certain parts of the country. And then, of course, there are the man-made environmental factors. For instance, hot tubs, indoor swimming pools, potting soils, shower aerosols, and so forth. You're getting the idea that these organisms are just hard to avoid in general. And then on the organism side, these organisms are extremely hardy. That's one of the reasons that they take so long to grow in culture. So it's a lipid-rich cell wall. It confers survival and growth in diverse habitats. They're also capable of biofilm formation and aerosolization, and they tend to be both antibiotic and disinfectant resistant. The growth requirements, these guys, because they are relatively slow-growing organisms, they can take up to 8 weeks to culture. And that's one of the reasons that we miss the diagnosis in clinical practice so much. There's also special media required to grow the NTM species, and so on routine labs, it's oftentimes missed. Now, on the host side, there are a number of susceptibility factors, some of which include bronchiectasis. Patients with bronchiectasis, whether it's CF or whether it's non-CF bronchiectasis, are many times more likely to develop this infection. And then there are certain disease associations, such as COPD and emphysema, structural lung disease in general, gastroesophageal reflux disease with supine microaspiration, immune deficiencies. This includes both inborn, heritable, as well as acquired. And then autoimmune diseases and connective tissue diseases are also commonly implicated. And this is just a slide about COPD. As I mentioned, if a patient has bronchiectasis, they're much more likely to develop this infection. However, we're increasingly recognizing that patients with other airways diseases, such as COPD, are also very likely to develop this infection. And you can see the divergence of these two lines on this graph here. So the NTM prevalence rate, as you can see, from 2000 to 2016 is rising in general, but you can see in patients with COPD, it's much higher. So what about the diagnostic criteria for NTM lung disease? So the 2020 ATS-IDSA guidelines laid out sort of 3 broad categories for diagnosing this infection. So one of them is symptoms compatible with NTM lung disease. The second broad category is radiographic or imaging presentation that is characteristic of the disease as well. So cavities, hopefully not cavities, but nodular bronchiectatic pattern, consolidation, and so forth. And then the third category is 3 respiratory cultures over the course of at least 1 week, the microbiologic category. And really you want 2 sputum samples that are positive for the same species, or you want a bronchoscopic specimen that is positive. And then from a laboratory standpoint, we like identification to the subspecies level, and if possible, we like macrolide susceptibility as well as aminoglycoside or amikacin susceptibility. And I will turn it back over to PJ.
Thank you. Thank you, Dr. Swenson. So we're going to now do the experts versus AI section, and I think this is going to be fun. So you will answer this question, and I think our chatbot will answer the question after you. So going back to what we've seen before, the 75-year-old woman with chronic cough presents for care to her pulmonologist and says that in addition to weight loss, she's experienced night sweats for the past several weeks. If the NTM is suspected, what would the next step be? Start empiric antibiotic therapy immediately, obtain the sputum sample for AFB, order the high-resolution CT scan, test for TB, or you're not sure. So we have your answer from last time we asked this, and we're going to see what the chat bot says. So we see that most of you elected to obtain sputum sample, which I think is a sensible answer. In a little bit, this was a trick question because it didn't automatically tell you that there was a CT scan available. So I think my colleagues may want to chime in here, but I probably would have gotten both at the same time because you want to make sure there's evidence of CT scan criteria for NTM lung disease, but there's no question that you probably should have sent off the sputum samples also at the same time. What do you guys think?
I think you're right, PJ. I think in clinical practice, we probably would have done both around the same time. I think that if a patient presents with chronic cough and night sweats, obviously high on the differential is infection. So I think that number 2 is a very reasonable low-risk answer.
Any comments, Dr. Drummond?
No, I agree with that. A lot of times when we do our evaluations, these things are going to happen in parallel, right? So you'll get sputums, you'll obtain a CT scan of the chest. I'm also going to just throw in there that I always get a routine respiratory culture as well. This could be Pseudomonas, although probably more likely to be NTM, but yes, I agree.
So the next step is we want to see when our hospital administrators decide to replace us with a AI. So I think we need our next slide to see. So the chatbot is receiving the questions, and so he says, if NTM infection is suspected in a 75-year-old woman with a chronic cough, weight loss, and night sweats, the next best step is to obtain sputum sample for acid-fast bacilli staining and culture. This will help in diagnosing NTM infections, such as those caused by Mycobacterium avium complex. Additional tests, such as chest imaging, might also be indicated. So I would say to my administrator, hey, that chatbot didn't tell us to get a CT scan, and there may have been something horrendous underlying there, like a cavity or even a malignancy that, would have been important. Any other comment? Okay.
How do you know it's a he?
That's an excellent, yes, I should probably say they.
They, yes,
okay.
yes. Non-binary, please.
Yeah. I'm sorry, I'm from Texas.
I can't do that.
Okay. But then the chat box said back to us, well, don't three sputum samples need to be obtained over the week? Okay, well, yes, you're correct. To increase the diagnostic accuracy, 3 sputum samples should ideally be collected over a period of several days. This approach improves the likelihood of detecting Mycobacterium species and helps differentiate NTM infections from other conditions. Each sample should be processed for AFB staining and culture. What do you think?
I mean, that is true. I would just highlight the term or the word ideally. I think that some patients it's going to be difficult to get 3 sputum samples, particularly in our more sort of mild nodular bronchiectatic patients. And oftentimes, if I get 2, I'm quite happy. But in general, I don't know, what do you think? 3, 4, 12?
Well, I agree with you. I think sometimes you're lucky to get 1 in some of our patients, and I think probably those of you in the audience may agree with that. But ideally, you would like to get 3 in the same week. And as I mentioned before, I'm also going to get a routine respiratory culture. And yeah.
So what about those patients who tell you, and you sort of mentioned this, Dr. Swenson, but they say, I cannot produce sputum. And if you run a busy clinic and you have lots of patients, you can't always bronch all of your patients. So what are some of your tricks of the trade to get that sputum out?
So I think instructions, in fact, there are some resources available online, including instructions on how to collect sputum samples at home. If the patient is on airway clearance, that's a great way to induce a sputum sample at home, 7% hypertonic sodium chloride. Many of my patients, that's what I do. If they're still not able to do it, what I tell my patients is that, look, everybody gets a cold, everybody gets a respiratory virus at some point. Most of us will produce sputum at that point. We can use that sputum. It will still give us the answer. So I tell them to keep it on hand. If the patient is really more sort of on the mildly symptomatic side, if they have more of a mild CT, we can oftentimes wait until they produce a good sputum sample to make that diagnosis. In some who want to know the answer, absolutely want to know the answer, if they're not able to produce any sputum, then there is a role, obviously, for bronchoscopy.
Dr. Drummond, do you have any additional tips?
I mean, if you're lucky, and I would say this is probably in the minority that would have access to respiratory therapists, if you can, for those very, very difficult patients that you really need micro data on, I've sent them to the hospital and had sputum induction, and there are some patients who either absolutely decline bronchoscopy or, for a variety of reasons, just cannot undergo a procedure. So that's also a strategy, although a little more challenging sometimes.
So I often find it very challenging, or a challenge that I like to take on in my clinic when the patient says that they can't produce sputum, and so we'll give them 2 sequential vials of 7% sodium chloride. This is something that I learned from a mentor, Dr. Wallace, at my institution, and we give them 2 in a row, and then flip them on their stomach and do the percussion in the room, and happily, we usually get it.
Yeah.
And so that's something that you could try. Of course, the patient can't just have had a spaghetti lunch before you do that.
And PJ should also notice, based on that it can help also recognizing where the bronchiectasis is. So if it's lower lobe predominant, you're absolutely right. Flipping them in clinic, maybe doing some chest percussion, some chest physiotherapy to get the sputum is great. But where the bronchiectasis is can sometimes help
Absolutely
us determine
guide
what
where
position.
you want it, what position, absolutely. So I think we have, we now will hear the follow-up AI question in our bottom of our screen. Of those 3 sputum samples, don't at least 2 need to be positive for NTM? So this is the AI's answer. For a diagnosis of NTM infection, typically at least 2 of 3 sputum samples need to be positive for NTM species on culture. This helps confirm the diagnosis and rule out contamination of other causes of AFB results. However, clinical correlation with symptoms and imaging is also crucial for diagnosis.
And I would just say the same species. So it says, positive for NTM species on culture. Some of these patients can isolate more than one NTM species, and it can become a little bit like a whack-a-mole situation, or not, really not being able to tell what's causing the symptoms. So really the same species is what you want. And also there's a lot of anchoring right now on 3 sputum samples. Some patients, will be able to submit more than 3 sputum samples, in which case we can still use those.
Excellent. Dr. Drummond, what other questions?
I think the key point is just trying to increase your diagnostic accuracy with having several samples, really. The other thing that I see in my clinic a lot is, there will be this long delay before the patient even gets sent to me, and so the sputums I have, or maybe even a bronch, is from 6 months ago. So at that point, if I'm able to even get one positive culture that actually correlates with symptoms and imaging, sometimes that's what you have.
I think the key is always the more the better.
Yes.
Right?
But it can be very nuanced, and I think that's,
Yeah.
yeah.
Okay, let's see what our, we've come to the end of our AI interactive session. So I would now like to introduce Dr. Wendy Drummond. She is a living example of a smart, beautiful woman, just stays smart and beautiful.
Thank you, PJ. Oh, there is that little echo. Okay, well, I just want to give a special shout out to those who actually did come from the West Coast, because I did. So that means you either got up at 2 or 3 to make this session. So kudos to you, and thanks for having me. Let's get started. So I'm going to talk about therapy and treatment, which is one of my favorite things to talk about. So thank you for that. So factors influencing the decision to treat, and I think, when the new guidelines were published in July of 2020, some of the additional information was trying to provide additional discernment around those people to treat. One thing we were talking about before the session is, someone walks into your clinic and you're immediately assessing them, including their body habitus. And so we know that patients with a lower BMI, that may be suggestive of more advanced disease, and we may be more reflexively treating them. But 10 to 15% of patients diagnosed with MAC lung disease can have spontaneous AFB negative culture conversion of sputum, and we're going to talk about that monitoring here in a minute. But characteristics of those patients included patients with a higher BMI. So as I referenced, that's, it's just going to give you a better sense of maintaining their weight, good nutrition. They're not having some sort of insidious weight loss. Sputum AFB that is smear negative, so that may be more suggestive of a lower burden of disease. And then patients with a nodular bronchiectatic disease phenotype, so the absence of cavitary disease. So I want to bring your attention over to the right of the slide. When we talk about treatment, I want to show you this algorithm. So I think Colin already referenced that when we think about who to treat, we're really thinking about those 3 diagnostic criteria, right? So patients with radiographic findings suggestive of NTM lung disease, they need to have the supporting microbiology that we already talked about in that AI session, but also the supporting clinical symptoms. We talked about chronic insidious cough, weight loss, potentially night sweats. So as you move down into that blue box, thinking about, okay, so I have a patient who has all 3 of those features, who am I really going to treat? And I think that there was a long era of watchful waiting, and as I mentioned, with the new guidelines, it did help provide some discernment around these patients that we're going to treat. So for example, patients with cavitary lesions on their CT scan, that's going to be more suggestive of advanced disease. And you're really going to want to strongly think about treating those patients. We already mentioned BMI, poor nutritional status, extensive disease, and I would say, for example, multifocal bronchiectatic nodular disease, but also multifocal cavitary disease. And then sputum AFB that's smear positive. So once again, that may suggest a higher burden of disease. And if you go over to the left for yes, an initiation of treatment, that's going to be pretty straightforward. And that no column over on the right of the slide. So first of all, regular follow-up. So I usually say that a decision not to treat is a deliberate treatment decision. And there's a lot of education that goes into this, especially with the patients, saying, okay, we're not going to treat you right now, but it's going to be really important to do ongoing surveillance. And what does that involve? Well, that involves clinical symptoms. Some patients come in and their clinical symptoms may be relatively mild. So if they're having progression of their symptoms, that's really important. Weight loss, for example, diminished appetite, progression of cough or new cough, or even shortness of breath. So, and then doing routine monitoring of sputums. We don't just want to forget about these people. So I bring them back maybe even 3 to 6 months later, depending on how concerned I am about the patient, and have them submit additional sputums, and sometimes even radiographic follow-up, depending on what their initial CT scan looked like. And then that takes you into initiation of treatment if they have progressed over time, or just routine follow-up as you've been doing. But once again, emphasizing with the patient that I don't want you to disappear. We need to be continuing to follow you over time. In terms of thinking about who we're going to treat, once again, is there associated cavitary disease? Well, that's definitely going to push you into that treatment category. How symptomatic is the patient? And this is something that should be assessed at every single visit. What are the patient's pulmonary comorbidities, and how stable are these comorbidities? Severe bronchiectasis is certainly one of them, and are they on a good airway clearance regimen for management of their bronchiectasis? And I can't emphasize that enough, because patients with bronchiectasis can have chronic cough, and that can really confuse the issue because they're more likely to have NTM isolated from their airways. Are they immunosuppressed? I mean, so many people are now on TNF-alpha inhibitors or other immunosuppressive medications, which can increase their risk for progression over time. Hearing loss is a consideration in patients for whom you want to start aminoglycoside therapy, especially IV aminoglycosides in the setting of cavitary disease, and other medication interactions. Some patients have hypothyroidism, and they're on Synthroid, and you're starting a patient on rifampin, for example, or patients are on antiarrhythmics or have a history of QT prolongation. And then what is their short and long-term prognosis? And then, of course, the patient's willingness to start treatment. And then we talk about just the importance of shared decision-making and communication, and a lot of this is the art of medicine, right? And that's the one thing about coming to these types of symposiums and conferences, is I do think you get a lot of the nuance that you're not gonna get strictly from reading a textbook or up to date. And a lot of this is right out of the gates, establishing that relationship with your patient, because they are chronic, you are following them over time, and setting expectations and doing a lot of education about the disease process. And we're running in parallel because these patients have bronchiectasis, and they're getting education about management of that, as well as potentially embarking on what could be a very long treatment course. And so, just a good discussion about the multiple medications involved. And I usually plan, when I'm going to talk treatment with the patient, I make sure that I have time to do this. This is not a 10-minute, 15, or even 20-minute visit. Discussing the potential for adverse events, and once again, it's expectation setting, like you may develop gastrointestinal symptoms, but it's also providing a strategy of how you're going to address those symptoms should they happen. We talk about hearing loss or tinnitus, potentially with aminoglycoside therapy, visual changes in neuropathy that can be associated with ethambutol, GI symptoms that can be associated with any of the above medications, and then kidney or liver damage. So once again, really thinking ahead and providing some support with the patient of how we're going to address those symptoms should they arise. Pulmonary hygiene and airway clearance, I can't emphasize that enough. Maybe it should be at the top of the slide, but it's really important that they're continuing to aggressively treat the bronchiectasis, because that really can be a confounder in terms of monitoring their symptoms on treatment for their MAC. The importance of aerobic exercise, we know these patients do better who exercise. And then nutrition is extremely important. These patients may be losing weight as a consequence of their disease. Then we start 3 new medications, any of which can cause GI symptoms. A lot of these patients have reflux, and so they're on special diets or have other strategies just to address their reflux. So nutrition can be really important. And then I think Dr. Swenson, Dr. Collins.
Dr. Collins.
Dr. Collins.
Yeah.
He's a pediatrician now. I'm going to call him Dr. Collins. So recent study results. So this came out in 2023, and this was a really interesting study because, and we knew some of this before, but among over 9,000 new MAC therapy users, and these were Medicare recipients, when we think about the guideline-based regimen, which includes a macrolide, typically azithromycin, ethambutol, and then typically rifampin, plus or minus amikacin, only 51% of patients were started on an appropriate guideline-based regimen at the onset of treatment. It's pretty astonishing because it's easy to access this information, right? There's guidelines are readily available, UpToDate is readily available, but I think that there's a lot of trepidation with these multi-drug regimens, not only on the part of the patient, but also on some of the physicians. Nearly half of those patients were prescribed a non-guideline recommended regimen, including regimens that can actually promote macrolide resistance. And we know that patients who have macrolide resistance have a poorer prognosis and less efficacy in their treatment program. Treatment discontinuation was extremely common, and once discontinued, few resumed therapy at a later time. And once again, I think that goes back to understanding that these patients do require time, patience, counseling, and a good support group in your clinic to help support these patients through that journey so that they can remain compliant. So why do so many patients not receive guideline-based therapy? Well, some people aren't started in the beginning because MAC treatment is prolonged, 12 to 18 months beyond sputum conversion to negative. And, it's really talking about that in the beginning of treatment. It is a long haul. And you're not just treating with one antibiotic, you're treating with 3 and sometimes 4 antibiotics. The other thing is that each one of these medications can potentially have adverse side effects or adverse events that we talked about before. The treatments do often require modifications, and I think that takes a lot of patience on the part of the patient as well as on the physician because, we're stopping medications. There's a period of time off of the medications before we reintroduce them, for example. And then if any of the guideline-based therapy drugs are discontinued, then dual therapy or monotherapy with macrolide may lead to resistance. And a lot of those patients in the prior study I referenced were on azithromycin with the fluoroquinolone. And it depends on your lab. You may not always have fluoroquinolone susceptibilities, and then you're essentially treating with one drug. And then lack of understanding of multi-drug regimens and susceptibility reports. Here's just an example of the treatment regimen that I just referenced, but essentially you'll have a macrolide. Azithromycin is our preferred macrolide due to fewer drug interactions and fewer side effects. In addition to ethambutol as well as rifampin, oftentimes we do use rifabutin, depending on, you may have a patient with underlying malignancy who's receiving chemo, and rifabutin is going to be a better choice for that patient. And then down there in the box at the bottom, you see clofazimine, linezolid or tadalafil, bedaquiline, and fluoroquinolones as alternative agents that you may or may not need to substitute along the way. If they don't have cavitary disease, thrice weekly therapy is appropriate. If they have cavitary disease and or just more advanced disease, then you want to use daily therapy. And in the setting of cavities, you're typically going to add IV amikacin. Side effects I've before, but just quickly, any of them can cause GI side effects. Rash, I always think of rash rifampin because that's the most common to cause a rash. Hearing loss can be associated with aminoglycoside therapy, but more often associated with IV aminoglycoside therapy. Hearing loss, tinnitus, or even a sensation of fullness, which is a tinnitus equivalent. Elevated LFTs typically is more often associated with rifampin. Leukopenia, thrombocytopenia, and vasculitis can also be associated with rifampin, or more of an idiosyncratic influenza-like syndrome. Discoloration of the urine or tears, I always think of rifampin red, especially when counseling the patient, just so that we have an understanding of which drug may be causing this. And optic neuritis and peripheral neuropathy, which can be associated with ethambutol. And there's a lot of counseling that we do with our patients in regards to the vision loss because it is reversible if you know about it right away and can discontinue that medication. Just in terms of some little treatment pearls, I typically introduce one medication at a time over the course of a week or so, starting in alphabetical order, so starting with azithromycin, followed by ethambutol, and then rifampin, and that allows you to really discern which medication may be causing potential side effects. I also typically counsel patients to take their medications at night. I do believe this improves their tolerability, especially with the rifampin, which needs to be taken on an empty stomach, ideally to promote absorption. In terms of side effects, if you're introducing one drug at a time, then you're going to have a better idea of what drug is causing what side effect. And then if rash starts down the road, let's say they don't have rash on the 3 drugs, even in the beginning. If they develop a rash down the road, then we're probably going to stop all 3 and potentially reintroduce. And then I already talked about troubleshooting for optic neuritis, but making sure that you really emphasize that they need to be reading fine print. If they have 2 consecutive days of visual changes, they need to stop the medication and go see the ophthalmologist. And then clinical follow-up. This just gives you an outline of the monitoring that we do. And once again, emphasizing that you should discuss this with your patient at the onset of treatment so they know what to expect in terms of monitoring while on this medication. So a baseline CBC and CMP. I usually get a CRP as well. And then follow up in 2 to 4 weeks after initiation of therapy to check for transaminitis, thrombocytopenia, and then every 3 months thereafter. In terms of follow-up radiographic imaging, it really depends on the patient. If they're on IV amikacin, am I going to reassess after 6 to 8 weeks to assess their progress? It's a very patient-dependent situation. And then monthly sputums if you're able, because that clock is ticking. Typical treatment duration is 12 months beyond sputum conversion to negative, and trust me, you and the patient want to know exactly when that sputum converts to negative. And then the last thing I'd like to mention is just that it takes a village to raise a child and also to take care of these patients. So just keeping in mind that you're going to have all of your whole treatment team involved. In terms of additional therapies, so we typically add Arikayce after 6 months if their cultures remain positive. And this was published in the 2020 guidelines that were published in July of 2020 as a standard part of your regimen. And I really talk about this at the onset of treatment with patients just to let them know that 6 months is a time where we really need to reevaluate. And just briefly, the composition of ALICE is, it's the medication, the amikacin is enclosed in this liposome for better drug delivery, and it helps penetrate biofilms created by the mycobacteria more effectively. And then just quickly, money slide here from the CONVERT study. It was a 2-to-1 randomization, 224 patients on the guideline-based therapy plus ALICE versus guideline-based therapy alone. And just to point out that 29% of those patients had culture conversion by month 4 versus 9%. And this is just a review of side effects, but keeping in mind that hoarseness is one of the most common, as well as coughing, wheezing, and shortness of breath. And there's a number of different strategies to address that. And I think just in terms of time, I'm going to hand it back to PJ. Thank you for your time.
Thank you. So we are going to go back to some of the questions that you answered already and see how the chat back responds to these questions also. So how often would you now consider the use of inhaled amikacin in the treatment-naive patients with non-cavitary MAC lung disease? Never, sometimes, frequently, always, I'm not sure, or this doesn't apply to me. So I think this might be the summary slide from Dr. Drummond's talk. So rates of NTM lung disease continue to rise, yet the diagnosis requires considerable time due to its slow growth, often misdiagnosed or delayed. The decision to treat NTM lung disease involves careful risk-benefit analysis and shared decision-making approach. Despite official guidelines, many patients do not receive guideline-based therapy, and I hope that today does a little bit to move the needle toward everyone using guideline-based therapy. Of course, we're probably preaching to the choir here. All of you, I'm sure, do this correctly. We have to encourage our colleagues out there who are not here this morning to do the same. Current guidelines recommend the use of ALICE, amikacin liposomal inhalation suspension, for patients who have failed guideline-based therapy after 6 months. And you can get through the side effects as you just work with your patient through these side effects. So now we'll go to the experts versus AI treatment. You answered this question previously, so we'll go pretty quickly. The previously introduced 75-year-old patient has now been confirmed to have MAC lung disease, and how do you proceed with treatment? You answered one of the following: treat with a short course of antibiotics for 2 weeks, start high-dose corticosteroids. Hopefully no one answered that option. Initiate 3-drug regimen with a macrolide, ethambutol, rifampin, and monitor the patient without antibiotics unless symptoms worsen or you're not sure. So let's see what we see. We're gonna go through the. I'm thrilled to see that no one answered to, the MAC and especially abscessus really loves that steroid. So I always feel like when I have a patient come in who's on a high-dose steroids, I need to look at their skin, not just their lungs, to make sure they don't have disseminated NTM disease. And we even, I bet my colleagues would say the same thing, or many experts here who are in the audience would probably even try to get them off the inhaled corticosteroid too. So I'm very happy that no one chose the corticosteroid route. And most of you said to initiate the 3-drug regimen. And it may be reasonable to monitor these patients. One MAC is not another MAC. And the only message that I think we would all want to make sure that everyone leaves this room is if you're not going to initiate therapy, that patient doesn't get away from you. I'm sure we all have our stories where patients were told that the treatment was worse than the disease and didn't get treatment, and then they return with a destroyed lobe and they have to have surgery for resection, and then it's a mess. So you just have to follow these patients. Any other comments?
No, I think you said it well.
Yeah.
Okay, all right, we'll keep going then.
Nailed it.
We'll move on to the next slide. Let's see how our chat bot says. My chat is going fast. Okay, for a patient with MAC lung disease, the first-line therapy typically involves the combination of the antibiotics that we've discussed. You must have a macrolide in there. I think this audience accepts that to be true. Regular monitoring for side effects and treatment response through the clinical evaluation and sputum cultures is essential. Ensure that we need to address these drug interactions with their other meds. Your lady with atrial fibrillation on flecainide, that lady may not be able to get a rifamycin that day, so you'll review her other medicines. But we have an additional comment. Shouldn't the patient be tested for macrolide susceptibility before prescribing the regimen? What does our chatbot say? Yes, our chatbot says, you're right. Testing for macrolide susceptibility is important before starting the MAC lung disease. Although clarithromycin and azithromycin are standard treatments, resistance to these drugs can occur. Yes, it can, especially if your patient has been going back and forth to her primary care doctor and receiving azithromycin for regular respiratory infections for the last 7 years. If macrolide resistance is detected, you're up a river without a paddle. Okay, if it is detected, you must consider an alternate regimen, such as those including moxifloxacin or amikacin or prayer that might be necessary. It's crucial to base the treatment regimen plan on susceptibility. I would even emphasize it's crucial to make sure that we tell all of our friends who are not in this room today that macrolide monotherapy should not be used in patients with bronchiectasis who are at risk of NTM lung disease, which is all bronchiectasis patients. We really need to make sure our patients understand this too, because they go out into the community and they have a trusting relationship with their primary care doctors, and when they get sick, their primary care doctors give them a macrolide or a Z-Pak. We really have to educate our patients to not receive this therapy. So we have an additional comment here at the bottom. Okay, we're going to go to answer this question. So the patient was confirmed to have macrolide susceptibility and cavitary MAC disease. So she's now on a daily regimen of azithromycin, rifampin, and ethambutol. She's experiencing adverse effects, which include rash, GI effects such as vomiting, and now she thinks she's noticing some change in her vision. What do? Do you continue this regimen and just say, take an antiemetic? Do you stop all antibiotics for 2 weeks and then reintroduce one at a time? Do you switch her to twice daily regimen? And do you discontinue ethambutol and refer her to ophthalmologic evaluation?
So much to unpack.
Lots of unpack.
It's a great question. A lot to unpack. I don't understand when we're supposed to do these.
I don't know either.
Okay.
Oh, we have a mix. So 51% said stop all antibiotics for 2 weeks and then reintroduce at one time. A few people said switch to a twice weekly regimen, schedule of the current regimen. And then 41% said discontinue ethambutol and refer. So, I mean, I think that we must realize that this ethambutol and vision changes is a big, huge brick wall that we must stop that ethambutol. And for me, that means stop everything. Because if I stop the ethambutol, then effectively the azithromycin is sort of monotherapy, or it's a regimen that, you know, encourages. So I have them stop everything until they get to the eye doctor. How about you both?
I mean, I think that you see the spread here because you would also have a spread and a diversity of opinions from experts here. But in general, I think I would go with number 2 as well, which is stop the antibiotics. I don't know for 2 weeks, but I would certainly stop the antibiotics until they get in to see an ophthalmologist, until the rash resolves and so forth. And then I would probably introduce one at a time. It should also be noted that ethambutol, if dosed at the 15 mg per kg per day, or slightly less in some cases, you know, the chances of optic neuritis are very, very low. However, we do see it. Certainly, the longer patients are on it. So I think that, you know, stopping everything, allowing things to resolve, and then introducing one at a time is a completely reasonable approach.
Yeah, I agree with everything that you guys have said. And this is such a great question because it's like a board question in a way, like an NTM board question, right? Because there's so much to unpack here. And as I mentioned in my talk, you absolutely are going to stop the ethambutol right away because we don't mess around with the vision changes. And one thing I would mention too is that what I've seen in some of my patients is occasionally neuropathy will actually precede the vision loss. So don't forget to do counseling around the neuropathy. That's just sort of a sidebar comment. If there was no rash in this situation, I might just substitute another medication right away if there was no rash. But when they have GI side effects and the rash and now the visual changes, you're going to stop everything and then strategically reintroduce.
Mm-hmm. I think we have somewhat the luxury of time with MAC lung disease, right?
Absolutely.
And for the most part, this is a disease that's going to go a little bit slower than optic neuritis. Mm-hmm. So I think when especially they mention something like a vision change, I think we have certainly the luxury of time to stop their medicines and see what the ophthalmologist says.
And I would also say with the rash too, there may be a role for immunology consult here as well to see, you know, because the rash will often, well, it could be actually due to any of the medications, but it's important to evaluate, you know, what sort of hypersensitivity reaction it is that they're having. I'm with you. If you have to stop the ethambutol, you really have to stop the azithromycin until you suss that out.
But the rash is usually due to rifampin in general. I say if you're going to roll the dice and play the odds. But.
Okay, so we will move on. It's early for these wrap. Okay, she's experiencing adverse events that include rash, GI event. Okay, so I think we've assessed the vision changes. We could go to the next. Our chat box says, given the patient's adverse events, including rash, GI symptoms, and vision changes, the regimen should be adjusted. Discontinue rifampin if it's causing significant issues, as it's common for side effects. Consider substituting rifampin with rifabutin. I'm going to stop reading right here. I mean, if the patient, here's where I think the doctor does better than the AI. Because if she said she's having vision changes, let's not mess around with the rash and the GI stuff. And the lady's having vision changes, we got to stop everything and see what the ophthalmologist says. If the patient's talking about rash or GI effects, we can jimmy around with some of these medicines, when they take them, how they take them. But I think if the AI did not first mention stop everything in the context of vision changes, then I think the physician won on that one.
Yeah, I agree, and especially, as you say, jimmying around with the dose of ethambutol, I would say we're in uncharted territory right there. It says consider reducing the dose or discontinuing the ethambutol, which of course you would not want to do and continue
that's
the
an excellent
azithromycin.
point, yes.
Yeah, and then the other thing I would say is, I'm not sure where it's pulling the information about rifabutin, but the tolerance with rifabutin is actually quite low. Lower than it is. I mean, I find, and I don't know if you find as well, that rifampin, when we do use it, tends to be better tolerated than the rifabutin.
That's excellent.
I agree
points.
with that.
Yes.
You got me. I was itching to say that. The only other thing I wanted to comment on,
Fist bump there.
there we go. I was going to leave him hanging on the fist bump. It says cavitary mac at the top of the slide, and there's no comment about the size of these cavities, but generally speaking, you're probably going to have IV amikacin on board. I just wanted to throw that out there, unless the cavities are pretty small.
It doesn't look like AI talked about surgical resection either, so I'm still going to argue that the human won. Ethambutol was replaced with clofazimine, and the vision changes improved. The rash resolved after a period of stopping the other medicines. The regimen was resumed successfully. However, after 6 months, the patient had failure of culture conversion. What would you do next? Would you add amikacin to the current regimen, switch the patient to corticosteroids to control inflammation, continue the current regimen for another 6 months to allow time for culture conversion, or switch from azithromycin to clarithromycin for better efficacy?
Ooh, now we've got like
A night
the
in
Gypsy
Verdant.
Kings.
Yes.
A night out in Spain.
Yes. Cha-cha-cha.
These are all good questions.
So most of you said add amikacin to the current regimen, and 9%, almost 10% said to continue for another 6 months to allow more time for culture conversion. Those are the last holdouters on this Alice train. And then 5 said, I'm not sure, to number 5, I'm not sure. There were 2% of you who put it out there, not sure. Probably, maybe because of the way the question was worded, add amikacin is a little bit vague. So we have, on the next slide, I think we'll go into more detail. Okay, we've got a lot of typing here. Okay. Okay, so if the AI says if culture conversion has failed after 6 months on the adjusted regimen, consider the following steps. Reassess susceptibility. Hey, that's a good idea. Okay. Review adherence. That's a really good idea.
Very good idea. AI beat us here.
Yeah, we were all focused on our Alice. Evaluate the regimen. Consider adding or replacing medications such as moxifloxacin. Okay, AI, come on now. Okay, consult an infectious disease specialist. Engage with a specialist for complex cases or potential alternate therapies. And continue. So let's review this. Certainly, it's super important to assess susceptibility, which takes that's kind of a long time, because one, it means that you're getting updated cultures, AFB cultures every month, and that your lab's on top of it and has grown a nice pure specimen and is ready to get those susceptibilities going. It could happen, but it's not immediate. Review adherence, that's fantastic. We should do that. And then consider adding or replacing medications. Well, everybody, there's not data for adding moxifloxacin in this context. There is excellent data for adding amikacin in the form of the liposomal inhalation suspension. That's ALIS. I mean, in fact, patients who got the ALIS actually stayed converted for longer, even after the medicine stopped.
A year after stopping, yeah.
So it really, there is data for that. There's no data for adding moxifloxacin or other medicines here.
And PJ, I'm with you here. One thing, we're talking about cavitary lung disease here. So really, amikacin should have been part of the regimen from the get-go, from the get-go. And so really, if there's culture conversion, I agree with 1 and 2, but at this point, you'd really want to consider surgical consultation as well.
That's an excellent point. So let's see what we have. We have another point down here in what form of amikacin is preferable. So I jumped the gun a little bit there in this context. I think Dr. Swenson already said very clearly, if you have a cavitary patient, you should be doing the IV amikacin or aminoglycoside up front for the first 3 to 4 months to sort of get their regimen going. And then if they stay culture positive after 6 months, then we initiate, in that case, at the 6-month mark, and we're talking about refractory disease, that's when the amikacin liposome inhalation suspension comes in. Mm-hmm. Any other comments?
Yay, we did it.
Okay, here's our AI guy or woman or they are saying for treating MAC lung disease, amikacin should be administered intravenously. The form allows for higher drug levels and deafness and better penetration than oral forms. Typically, IV amikacin in severe or refractory MAC is often part of a multi-drug regimen. I don't know about there, Mr. AI, Ms. AI.
No, I think Ms. AI here really, they have really had, they failed here because we know better penetration into the lungs compared to oral forms. There is no oral form of amikacin. So,
yeah.
So I think that was a fail. We know that amikacin concentrates much better in the alveolar macrophages with the liposomal formulation, the inhaled liposomal formulation. So I would just add that.
Any other comments, Dr.
And once
Gomez?
again, it's so nuanced. It depends on if they have severe cavitary disease. And PJ even referenced earlier, some of these patients may even need to be considered for surgery. So, depending on the size of the cavities, some of the, that male phenotype with upper lobe cavitary lesions need to go to surgery. But once again, I agree with everything else that you said.
Yeah. Oh. Yeah. Well, isn't it associated with significant toxicity? And yes, we feel this every day. So it is, the AI says intravenous IV amikacin is indeed associated with significant toxicity, including nephrotoxicity, ototoxicity. These necessitate careful monitoring during your treatment. That's for sure true. To mitigate these risks, the dosage should be adjusted based on therapeutic drug monitoring and renal function, and the duration should be limited. In cases where IV amikacin risks outweigh the benefits, or when long-term is required, alternate treatment options such as amikacin inhalation, liposome suspension may be considered. I feel like this is kind of missing the mark a little bit as far as that last statement. I mean, we typically don't have data at this time where we can start ALIS from the beginning in treatment-naive patients, nor do we have it really for specifically cavitary patients. But the upper paragraph is completely true, is that when you're initiating that IV amikacin, whether it's daily or 3 days a week, and I know that many people have different strategies, daily versus 3 days a week. We need to follow trough and peak levels, and we need to be in touch with our patients regarding their hearing at baseline. Get an audiology evaluation at baseline to make sure that that doesn't change, and talk to them about tinnitus, and then follow their renal function. Any other comments? There's a lot there to comment on.
Yeah. Well, one thing I was going to mention is that it takes a village to take care of these patients. That's where your pharmacist is really going to be important in the management of someone who's on IV amikacin. They can calculate your Cmax and help target therapeutic doses and minimize side effects.
And I would just say that the guidelines, the 2020 guidelines that you referenced, there's nothing in there that says, if the patient has refractory MAC lung disease, treat them with IV amikacin. And then if they don't tolerate it, go to inhaled liposomal amikacin. It's go to inhaled liposomal amikacin as add-on treatment. So I think the bot was a little misleading in that respect.
Well, there were so many other nuances, and I wish we just had all day to sit here and talk about this, but unfortunately, I think we're at time. And so as a summary or discussion of our experts versus AI, how would the faculty have proceeded with artificial intelligence in the decision-making of our patients? There were key differences and similarities that we saw between AI and the physician standpoint. And I think we saw a couple of maybe inaccuracies or maybe just missing the mark of the AI versus what a expert physician might do. And we also saw some benefits, even in the context of limitations of the AI in patient care.
And I would just say we also have a number of really good questions that have come. Unfortunately, we are out of time and cannot do the Q&A, but we will look these over and choose the recipients of the Amazon gift cards.
Okay.
And you can always grab us after the session, and we can talk through your questions with answers.
As we move forward in our careers, we'll all be interested, I'm sure, to see how much AI interfaces with our day-to-day job. But thank you for joining us for this session this morning. It was nice to have all of you here. Oh, we have to pick the winners.
Okay.
How do we do that?
Well, we have to confer. Yeah, go ahead and start. Cue the music.
Yeah, that's a good one.
That's a good one. Yeah.
Okay.
Yeah.
Okay, how many?
That's a good
How many?
one too. How many do we have? 3. Okay, top 3.
Oh, that one's good too, though.
Which one? This one?
Yeah.
Yeah.
No?
Maybe.
Oh, that, but yeah, the different species.
Oh,
Lung
boy.
transplant evaluation, that's always-
That's high-level stuff.
I feel like that's really good.
Okay.
Okay.
I think.
I don't think I see everything that you do.
First
Okay.
name, last
First
initial.
name, last initial.
I think we agree that Thomas M. is one of the recipients.
Yes. Thomas M., you've won a
Come on up.
Amazon gift card.
And then,
Woo!
And then, let's see here.
you
think
have more
that-
than I do.
Do we have an Amazon gift card to give him right now?
I think so. This one just says, it's a good question, but it just says moderator.
Oh, okay.
Got it, sorry.
So how about this one?
Okay,
Let's just, yeah.
that one. Okay. So,
Who knew it'd be so hard for us
and
to decide that?
Raji A. Oh, that's the ARS. Yeah.
What's ARS?
Okay.
Yay!
I'm sorry, you guys, I have to go to the
It's good to see you. Yeah. You can I don't have all of those, so. Just pick one.
Okay, and then Jennifer W.
Is Jennifer still here? Jennifer W. Thank you.
Of course, yes.
Yes.
First question is, Every time I put somebody on Alice, they hate me. They can't hold me.